Right, okay, so good afternoon, everybody, and welcome to today's webinar. We're very pleased to welcome Andrew Hynes from the NHS Legal and Risk Services, who is joining us today to deliver what will be the first webinar arranged by the IOSH Health and Social Care Group. Hopefully the first of many to come. And a big thank you to Andrew for agreeing to present this session. So whilst Andrew is just preparing his screen to be shared, I just want to mention a couple of things before we get started. So firstly, for those of you who haven't attended one of our IOSH webinars, I am Ben Pollard and I take care of the technical aspects of these sessions. Any problems and I shall try to assist as best as I can. So on your screen then, located at the top left-hand side, you'll notice a small bar and some written options on them, which are chat and Q&A. If you have any technical issues or audio problems at all and you need to message me, please do so using the chat option. If you have any specific questions for Andrew relating to the content of the session, please use the Q&A option and ask your questions here. I'll run through all of these with Andrew after the presentation is finished, and we'll aim to tackle as many of these as possible in the time we've got. If we do run out of time and there are still questions unanswered, we'll look to provide some written answers at a later date, which we can then post online, and we'll be able to get those over to you at some point. So with all that said, I'm going to now hand you over to Andrew. And Andrew, if you'd like to steal the screen onto your own presentation, and over to you.
Thank you, Ben, and thanks everybody who's paying attention today. My name is Andrew Hynes. I'm a solicitor working for the NHS exclusively, have been for 20 odd years now. And I'm going to talk to you today about violence and the growth of violence in the health and social care sector. My particular experience lies within the NHS, which I think covers probably both areas, but perhaps not so much in care as in hospital settings. So just moving on with the presentation then. An elephant in the room. Violence in healthcare, in my view, is a very large elephant in the room. And the combination of an aging population and increased longevity means that the size of the hospital and care population is increasing, as is the average age of our patients. Older patients will tend to present more frequently with cognitive impairment in addition to their medical issues. And the demographic will logically lead to increasing incidents of violence and aggression against staff in general medical wards, as well as in mental health settings. The management of the impact of all this is a reality and a key challenge for all health organisations. And I, as part of my role, have been making representations around this for more than a decade now in Wales. And obviously people are trying to respond to this, but it is a huge difficulty. And I'm hoping that some of the things that I've come across in my experience and that I'm passing on to you today in this webinar will be of use to you. I do hope that you can ask us some questions as we go along, and I will answer them at the end, as Ben has pointed out, and I hope you find it interesting. Looking at some of the statistics, we prepare a 6-monthly review for all of our personal injury clients in Wales, and violence and aggression civil claims have gone up through the roof. You'll see we currently have around 145 of these claims, and you'll see the way that it's increased in the last few years since 2012. They've doubled since then. They are now more prevalent than patient manual handling claims, of which we've only 36. That low figure has been achieved by good risk management, and I hope we can repeat the process and reduce the violence claims in the same way. Claims, of course, are the tip of an iceberg, and I'd estimate that less than 50% of patient or staff assaults are actually reported for various reasons you're all familiar with, and I'd estimate that only 5% of incidents end up in criminal or civil courts. Capturing this information is one of the most important things, and I've been talking about this for many years too. The central importance of incident report forms. Of course, when I started in the NHS, we used to have the written report forms, which were useful in some ways and in other ways not as functional as the current DATIX type reports. But certainly the incident report form takes the position of a conductor within a symphony for me. If we can manage to investigate and complete an incident report form, then that will be the trigger for all of the matters which are necessary following an incident of violence and aggression. All the objectives very much depend on whether or not the form is filled in, and they are certainly achieved more easily when one is completed and completed comprehensively. You can see here with this simple diagram that there are various issues which, or bells, which the incident report form will hopefully ring. Emotional air for employees. Let's start with how important being listened to is to employees. Then we look at prevention. We need to capture the information to analyze trends, and so that we can bring to bear our troops in risk management as effectively and as efficiently as possible. Managers can assist to identify these trends and make a case for extra resources in terms of training and additional staff. Human resources or workforce, this will corroborate the incident for benefits purposes, so our employees are given what they need to get by during the times that they're injured. Proper investigations will be a key theme in this talk, and key prompts will result from the completion of an investigation and an investigation report form. And of course, we'll get the RIDDOR report where appropriate later on. The litigation department provides vital evidence for the investigations. We'll then have medical support. Procurement department can look at the defective equipment issues. Estates departments can concern themselves with environmental repairs. And of course, occupational health can oversee the recovery process of your employee. I'd like to move to a case study now, because I know that you're all very interested in real stories, and this is a very interesting story. It's a case that we took to court on behalf of one of our local health boards just 2 years ago, and at first instance we lost the case. The district judge didn't find for us, but we were committed enough to the case to take it to appeal and felt that the judge had got the matter wrong. And I'm now going to give you a précis of that case, and I would urge you all to listen quite carefully. The judgment from His Honour Judge Bidder was very well written. It's a very eloquent judgment and touches along an awful lot of issues that I think are important in these sorts of cases. So without further ado, we have a claimant working as a healthcare assistant at a mental health unit on the 9th of April 2013. When she was helping to restrain a patient, she was injured. On the evening of the 19th of April, the patient, CL, and another patient were permitted to leave the ward to go to the shops. The decision to permit leave was made by the nurse in charge in accordance with a written policy permitting unescorted leave, which was formulated and considered earlier by a multidisciplinary team. The nurse in charge warned the two patients that they would be searched upon return to the ward and breathalyzed. They in turn assured her that they did not attend or they did not intend to buy any alcohol. Whilst they were absent from the ward, the nurse was told by other members of staff that one or other of the men had both previously supplied other patients on the ward with alcohol. Suspecting that the men may return intoxicated, she immediately contacted other wards to warn of the potential need for assistance when the men returned. Thus, when men did return, although they were allowed into the premises, there were 4 members of staff waiting them just in case an untoward incident developed. The 2 patients were jovial, giggly when they came back. And importantly, there was a video intercom system at the building which allowed the nurse in charge to observe and analyze their behavior before allowing them back in to the premises. Both men unfortunately refused to be breath tested, and sensibly the nurse in charge separated them. CL had a plastic bottle of vodka in his hand and refused, unsurprisingly, to surrender it. He became aggressive towards the male nurse, and the staff attempted to restrain him. There were 4 members of staff in the initial restraint. Another member of staff sounded the alarm. The claimant, for her part, came from another ward in response to the alarm and became involved in the restraint. She grabbed the patient's arm and, when the group fell over, she injured her elbow. At the trial, the district judge found for the claimant the defendant appealed on the basis that the district judge was wrong to find liability on the sole basis that he had held that the defendant had failed to prepare a risk assessment in relation to the return of the patient to the ward without identifying how the lack of that very risk assessment in itself caused the accident. It's a common problem. The judge is simply saying you didn't risk assess, that's enough, without telling us what difference a risk assessment would have made. Obviously, we were very disappointed with that. On the evidence and on his own factual findings, the defendant contended that even had a risk assessment been made, no steps would have been taken that were not taken, and nothing would have been done differently in any event. Once the judge had found that there was a breach of duty in this case, because of a failure to risk assess the return on appeal, the judge agreed that the evidential burden shifted to the defendant to provide some evidence that the accident was not caused by the breach. If that evidential burden was satisfied, then the burden of proof would shift back to the claimant to establish a causative link between the breach and the damage. The defendant contended that the district judge did not make any positive findings of the causative impact of the breach, and in one of the paragraphs of his judgment, he said, "The claimant succeeds in proving to me, on the balance of probabilities, that the failure of the defendant to prepare a risk assessment shows me the breach, hence negligence is established, as the claimant suffered injury which was entirely foreseeable. If it was the intention of the judge to make a finding that the failure of a risk to risk assess established a breach, it was incumbent upon him to explain why the failure did make the working environment unsafe. This," said the trial judge on appeal, "he singly failed to do." The judge does not make any findings about what specific risks were not catered for and what could have been done by the defendant more than what was in fact done. The witness evidence of one of the claimant's witnesses, one of the people assisting, was that 3 specific criticisms arose in the way in which the return was handled. More staff, she said, should have been involved, more men should have been involved, and there should have been proper planning for the return. And the judge in the first case suggests she may be right or wrong in her view. What the judge does not do is make a finding that she was right in her criticisms. The judge has accepted that planning for dealing on his return with a potentially disruptive patient is likely to be incorporated in safety training and restraint procedure. It's important to note at this point that a lack of training was not an allegation pleaded on behalf of the claimant. We had produced documentation demonstrating that all of the staff involved had been fully and properly trained in restraint. Because the claimant did not rely upon this, it wasn't open to the judge to make findings thereupon. The number of staff who were called to be present was absolutely adequate, and how the restraint was attempted when he became violent was essentially a matter of training for the staff involved. And the defendant's case was that the staff were trained to deal with the aggression appropriately and indeed did so. In terms of vicarious liability, there was no criticism of any individual staff member by the judge, which directly involved 4 or 5 staff members doing their best. The judge recognizes that there could be no criticism of female staff participating in a restraint and makes no criticism of the actions of any of those who were involved, recognizing that the pleaded case for the claimant did not suggest there were errors in training, as I've already pointed out. When the judge deals with the decision to allow leave, he recognizes that there was no legal basis to detain CL. He was a voluntary patient. He was therefore allowed to go to the shops, and he had done so in the past without incident. The judge noted that the multidisciplinary team, while taking an overview of whether an individual patient could potentially be allowed to leave, left a final decision to the nurse in charge. And this was because the nurse in charge knew the individual best and knew that individual and how he was behaving on the day that was going to be the subject of the leave. And I think that's an entirely sensible way of managing things. Decision had properly to be left to as close to the time when the patient was to leave as possible, and indeed that was done quite sensibly. The district judge didn't appear to recognize that the MDT inherently involved anticipating that the patients might return compromised by drink. The appeal judge made it perfectly clear that he felt it was artificial to suggest that the issue of the patient's return could be separated from the risk assessment which went into his being allowed to leave in the first place. Effectively, there is not a separate risk assessment required for the return as opposed to the leave. No decision made either by the MDT or the nurse could ever guarantee that a returning patient would behave in the way that he did. And the judge doesn't criticise the risk balance in relation to those decisions. What a risk assessment of the return actually is a process of planning for the return. And there was considerable evidence, as I've already mentioned, that planning had indeed taken place. The scuffle in question occurred rapidly in response to the bottle of alcohol being requested from CL, properly so, as it endangered others upon the ward. One of the submissions made, which was quite amusing by the claimant's barrister, was pub leave frequently granted at your hospital? It didn't take them too far, thank goodness. Moving on, the claimant had submitted that planning for the return should have had guidance on how to administer the breathalyzer, but the problems in this case simply did not arise because of aggression in respect to the use of a breathalyzer, and so that was dismissed as irrelevant by the trial judge. The judge then did not criticise the decision to allow CL back onto the ward, nor could there be any criticism of the planning and restraint that was exclusively a training issue. He made no criticism of the number of staff involved, and obviously it's impossible to say why 5 or 6 rather than 4 or 5 would have made any difference to the outcome in this case. The evidence was, as I've stated, that CL had never been violent to any member of staff in the past. The oral witnesses for the claimant accepted that there was planning for the return. There was positive evidence from the defendant in the form of testimony from the unit manager that not only had the staff been trained in restraint, but that policy and procedure had indeed been properly followed. It was not an option to allow CL's return, not to allow his return, a matter accepted by the judge. He could have presented a danger to himself or others if he'd not been allowed back into the unit. If there were an evidential burden on the defendant to establish all necessary steps were taken, it was discharged, and there was no evidence from the claimant capable of rebutting this evidence. The conclusion of the trial judge then is that it was simply not open to the judge to conclude that it had been a breach of Section 3.1 of the 1999 regulations to risk assess, or that there was a failure of the employer or occupier's duty to make a sufficient and suitable risk assessment of the risks presented by the return of the patient CL. The MDT decision to allow the nurse in charge to leave inherently contained within it consideration of the possibility of an intoxicated return. Not only that, but having had some pre-warming, the CL may return intoxicated and might have alcohol within, the nurse in charge had planned his return. More staff had been readied, including a male member of staff. CL had been warned he might be breathalyzed. There had been extensive training of the staff in how to deal with aggressive patients, and there was positive evidence from the restraint. Procedures had been followed, which was not rebutted by the claimant. So we move on very quickly to consider breaches of the manual handling operations regulations, and it was held that moving a patient, restraining a patient indeed fell within the regulations, but again, there was no absence of a suitable and sufficient risk assessment, which was covered off. The circuit judge then concluded that the judge was wrong to find liability against the defendant either in negligence or in breach of duty, and in addition, he could not have correctly found that there was a causal link between a failure to assess the risk of CL's return and the accident based on the factual findings that he made and that were in the circuit judge's judgment inevitable given the evidence. He therefore allowed the appeal and dismissed the cross appeal, and that is a judgment which is a matter of public record. So just a few comments on that, and with me today is Chris Beadle, who attended the entire trial, and I think it's important for health and safety practitioners to do that as often as possible. It was remarkably insightful. Chris has come to a number of subsequent trials and is very, very heavily involved in dealing with health and safety cases with me at Legal and Risk Services, much to the benefit of my investigation processes and also to the benefit of the preventative measures that we learn and we promulgate following cases like this. This was an expensive case. It was an extremely brave decision by the health board to appeal. It serves a really strong purpose in admonishing the staff, telling them that it is worth the paperwork that they have to repeatedly complete when dealing with difficult patients. It's all too often a complaint to me as an investigator. Why are we doing this? Nobody takes any notice. But in a case like this, we really brought home the fact that this paperwork was important and useful. And I think it's encouraged the staff, certainly at that unit and at others within that health board, to be as accurate as they possibly can be in working within these safe systems of work and producing the risk assessments. There are strong links between us then, health and safety and mental health, and I think that cohesion certainly is going to bring benefit for that particular health board in due course. Okay, so moving on to some analysis of that and how we can help you with that and take something away from today. I talk about risk integration here. Now, in relation to the prosecution of perpetrators of violence, the potential prosecution of health boards for something as nasty as corporate manslaughter, and in the civil cases like the one we just dealt with, you'll see here in the slide that there is an investigation conducted, and these are the investigation topics that are necessary in a violent and aggressive case. These are key subject areas, and I would urge you to try to adhere to these. First of all, we need to ensure that the facts are corroborated, and in the past case, you can see that the facts were not in dispute in any way. We look at generic risk assessments, and there was a generic risk assessment for unescorted leave, and a decision to allow the patient to go was set out and outlined by the MDT, and a specific risk assessment was carried out when the final decision on unescorted leave was made by the nurse in charge. An environmental risk assessment would import control measures in this case, such as CCTV at the entrance to the unit. In terms of the placement of the patient, whether or not a patient is being treated in the right environment is often a subject for discussion in terms of breach of duty by a health board. In this particular case, it was a voluntary patient with ongoing requirements for treatment, so he was entirely within the right environment. We turn then to training of staff. This wasn't pleaded as a breach of duty. The staff male to female ratio was something that was touched upon incorrectly, in my view, by the judge, but it just goes to show sometimes that you have to be very clear in your explanations to judges about what it is that women and men now do in the workplace. And I'm not being critical of the judge. I think it was a natural reaction and one that he in fact did move away from later on in his judgment. But it is an important thing to emphasize that there is no specific requirement for men as opposed to women. In terms of contributory negligence, the claimant's conduct was not criticized at all. And I just want to point out here that if you're considering going down the route of contributory negligence, remember it needs to be negligence on the part of the claimant, much more than mere inadvertence in doing something perhaps not quite as well as you normally would. In terms of equipment provided, the breathalyzer is the equipment in this case, but it wasn't relevant to the violent reaction because it didn't prompt in any way the violent reaction. We look lastly there at vicarious liability, and there was no factual finding that staff assisting didn't indeed follow their training or do the very best that they could in accordance with the safe system of work that was outlined for them. You'll see that the issues in the civil case and the issues that you guys need to look at when investigating a violent incident overlap. Prevention is far more likely if the duty of care is met. If you do all the things in terms of meeting your duties of care along these various different headings, then you're not going to be held to be liable. A defence is again going to be far more likely if a duty of care is met. Don't forget that when we get a case like this or any other legal case, the hidden organisational costs are huge. Management time, the divisive nature of proceedings upon the relationships your staff have with one another, the loss of new and trained staff, the disintegration following that of teams that have been working well together in a skillful and orchestrated way. The morale of the staff is often battered by litigation, and the outcome is often falling standards of care, which needs to be avoided. Moving on to a case which might involve an assault by a patient upon a member of staff. Again, these issues are also very relevant to prevention and also to the investigation by the police and the CPS of those cases. And thirdly, just say, for example, in a case like this, the unfortunate claimant was killed in some freakish accident. The very subject matter headings that you see here deal with each of the criminal requirements in terms of statutory duties. They will be analysed one by one, and you need to be able to demonstrate to a court that you have met that duty of care in every case. It is really important to remember that this can even be very relevant to a clinical negligence case. So this analysis and this prompt for the way that you investigate violent and aggression cases is very, very useful for all of these different types of cases. Okay. As I say, I've been working for many years looking at how to manage intentional and unintentional violence. Now, the difference obviously is that there will not be any mens rea in an unintentional violent incident. And of course, you will all know that by far the majority of incidents that result in violence in healthcare are unintentional. And it's only right that we as healthcare providers recognize that and exercise appropriate temperance in the way that we deal with these incidents. So looking at managing unintentional violence, this is a driver diagram that I prepared for a project that I completed a number of years ago and advice that I gave to the Welsh Government. The aim is preventing staff injury at the hands of patients by ensuring best practice is applied in risk management in all clinical environments, and emphasising NHS staff well-being is as important as that of the patients. I think perhaps there needs to be a little bit of a change in a paradigm here. I think that violence is a clinical as opposed to a health and safety issue, if I'm honest. If it was dealt with in the same way as perhaps bed sores can be dealt with, where you have continuous reports, feedback, reanalysis, and methodology change, which is insisted upon by management and by government, then I think we get a little bit further, a little bit quicker. Now, the drivers for all these things: engagement of NHS staff in recognising the utility in incident reporting and risk management. You all know this. And also reasserting people to understand that they have a huge value as a member of staff. They don't have to put up with this sort of behaviour. Mandate and design a specific violence and aggression policy for each clinical area, which includes restraint and assistance pathways. Demonstrate victim-centric reactions to all assaults. Very important matter. Appoint lead individuals for each clinical area to monitor and report trends in violence, and add this to their job description. So it's not something that they can simply do when and if they feel like it. We then need to provide training in best practice for risk assessment, incident reporting, and incident prevention throughout the organisation. Dealing finally then with interventions quickly. Widespread distribution of questionnaires with feedback reports. Just trying to find a baseline is quite important. Workshops, roadshows, publicity, changing again the paradigm of patient before nurse, which is a difficult thing to do. It's not by any means easy, but I think given the growing nature of the problem, we need to do something reasonably drastic. I think we need to identify minimum best practice standards, tailor policies to the needs of each clinical practice area, provide implementation and monitoring of feedback to ensure adherence to policy. This closing of the loop is really, really important. Setting up pathways of reaction to assaults, facilitating recognition and empathy from senior staff. A message from a chief executive officer or a member of the board to a relatively lowly employee can mean an enormous amount. And that sort of information will demonstrate to all of your staff that you really are concerned for their welfare, and it is indeed important to you. I'm happy to say in Wales that the Ambulance Trust have already helped me with a successful prosecution by providing a victim impact statement from the Chief Executive Officer, which went into the Magistrates' Court and no doubt had a decent effect in securing a bigger sentence, because the magistrates understood, if you like, the community effect within a service such as the ambulance service and what had been done to one of the paramedics. We then need to identify a lead for each clinical area, agree a reporting frequency at senior nurse level, agree a pathway for reporting to the Welsh Government. Apologise there for leaving in Welsh. I am Welsh, very proud to be Welsh, but I think this applies equally in all of the United Kingdom, which I'm very proud to be a part of too. We need to demonstrate responses to problems, and we need to absorb best practice which exists in terms of the assessment, anticipation, and dealing with violence, which has been honed over many years by mental health and learning disabilities in terms of risk assessment and training. We need to use those tricks. We need to identify them and bring them over to clinical areas. That's something that simply hasn't been done frequently enough, in my view. Identify triggers for violence in each area and identify appropriate training for individuals. If you do all that, I'm not saying that the problem will go away, but I think that the problem will certainly be something that you'll be able to manage better. Okay, the third part of this talk, I note that I've probably around 10 minutes left. I'm going to deal with how we in Wales have dealt with the terrible problem of intentional violence upon our staff members. And we worked tirelessly over the last 18 months, and I say we, that's myself, and members of a group that I formed called the NHS Anti-Violence Collaborative, to bring together the CPS, the police and the NHS, and all unions and adjacent people involved in this, victim support and people like that, to make sure that we could set up a pathway which would capture violent incidents and allow us to take them forward to suitable and appropriate prosecutions where necessary. This agreement was released in Wales in November. It's hugely successful. We're still bedding it in. The way that the document has been designed is very user-friendly. You'll see that there's a QR code on the front of the document which will allow you to access the website. We've used tech wherever we can in relation to this document. Here, I tell you where the full document is available. So if you went to that particular link, and this will be made available to you following the webinar, you would see the whole text of the agreement. The way that the agreement was designed, though, was to make it very digestible. And so the paper version of the agreement simply looks at matters 1 to 11. So it's a reasonably quick document to read through. It's supported with operational guidance, which is very detailed, and the annexes in there. I point out at this stage the advice for victims. It was very important to me and to the unions that we made the victims of violence central, front and center to this agreement, and that we actually did achieve. There are a few important subject areas that were changed from earlier iterations of this agreement that I think I will take you through. But first of all, I want to talk about the intent of the agreement. And there you will see the NHS has first responsibility to identify and respond to violent incidents in order that this agreement can be energized. Improved incident reporting is crucial to our success. All incident forms involving violence upon staff should be reviewed by the health body in order to inform improvement in risk management initiatives and to reassure staff that reports are reviewed and worthwhile. The agreement applies to, you'll see at the top, not only hospital staff, but also ambulance, community, primary care, dentistry, and all public sector staff undertaking caring duties. It's very important that everybody working in health and social care could take a benefit from this particular agreement. We refer again to help for the victims. I'd also like to take you through a simplified process of the whole agreement. You'll see again, I simplified it and I emphasize the words prevent, capture, investigate, prosecute, and deter. It's essential that first of all, the NHS and any other social care provider prevent assaults using effective risk management procedures. It's essential that we capture by oral report, hopefully by DATEX and subsequent investigation reports, exactly what's happened, and involve the police where appropriate. In Wales, we have dedicated violence and aggression case managers whose role it is to parachute in to a violent incident and speak immediately with the victims if they can, and to establish exactly what's happened and provide an excellent liaison point between the victim management and the police and CPS. The investigations are partly conducted by the case manager, but we of course defer to the police as appropriate, and we assist in those investigations when we can before a referral is made to the CPS. The prosecution then is considered by the CPS, and the violence and aggression case manager facilitates information sharing and supports the victim throughout. Victim support are introduced as well, and there is a real intention to provide good victim focus in all of this. Finally, deterrence, and we're looking to make sure that the health body provides director level service impact statements, as I mentioned earlier, and victim statements in conjunction with the police. Once sentence is passed, we have strong links with the media. And then at the end, very importantly, we close the loop off by ensuring that the NHS reflect and refine preventative risk management to make sure that these things don't hopefully happen again in the future, and things that have gone wrong are put right. I'm going to close with a mention of one of the most important other issues that we touched upon in this revision of the agreement, and that relates to the intent of a criminal to commit a crime. What we did find when speaking to staff and speaking to case managers and speaking to police officers was that often when they went to perhaps a mental health unit, or any suggestion was made about the cognitive ability of the patient, the question of capacity would be raised, and too often somebody would say that the patient didn't have capacity, and the police officer would do a U-turn and walk out, and the opportunity to do anything about this would be lost. So we wanted to look at that afresh, and we did look at that very carefully. I'd like to thank all of the people that helped me with that, particularly Mike Brown of the College of Policing, who had many a long argument with me about what was right and what was wrong, and we've settled upon this now, and I think this is a really good way of changing things. So I'm going to read it out as the final gambit for this talk. This agreement contains revisions which seek to assist officers attending NHS premises to recognise that the first step in assessing whether a prosecution will go forward is to assess the factual evidence in a case. Officers should be reassured that questions concerning the patient's intention to commit a crime are complex and will be reviewed and explored as the case proceeds. Officers should be extremely cautious in making findings at the scene about capacity which forestall further action, as mistakes at that stage are often impossible to reverse and serious miscarriages of justice can result, threatening public safety. Civil, not in criminal law, has been used in this area as a proxy term for mens rea, and this needs to end. Finally, I'm very happy to announce that the Welsh Government is keen to adopt this document. It's supported the document throughout, but it is going to convert the document into a Welsh health circular status, which doesn't quite make it legislation, but it makes it something that is mandatory for the boards to observe and comply with. Now, this initiative, coupled with the recent legislation increasing sentences against the perpetrators of violence in emergency work cases, is a great forward step, and I'm happy to say we're already seeing the benefits of that in a number of cases that have already been dealt with. I hope that the talk has been interesting for you, that you take something away with you. As I say, all the documents will be made available. Thank you once again, and on behalf of my organisation, Legal and Risk Services, thank you for inviting me here to give this talk. Thank you.
Great, excellent. Thank you very much, Andrew. That's brilliant. Okay, so Andrew, we've got a few questions here. So I'm going to kick it off with the first one, which was with regards to the incident reports. And that was, is there any thoughts that you have about why the number of reports has leveled off at around sort of 140, 150?
No, it's 145 present and ongoing cases where a staff member has been assaulted by a patient, and the staff member believes that there was more that could have been done to prevent that happening, and therefore they've submitted a claim for money damages in negligence.
Okay, brilliant. So another question has come through here, which is there any guidance offered to staff on what sort of level of aggression or challenging behaviour is to be recorded?
You know, in terms of preparing statistics, that is going to be a very, very important consideration. You know, what the threshold, if you like, is for violence and aggression. I'm not going to be specific about this, but I do think that the general view is that staff accept too much in terms of verbal abuse and in terms of physical abuse. Certainly, I've dealt with a number of very unpleasant cases where if staff had nipped it in the bud because they felt empowered to report, even to report to a colleague what had been said to them by a patient, then things would not escalate to the level that they unfortunately did in the end. So it's very difficult to say where the threshold should lie. But I think what you need to do is to make sure that staff are aware that they are important to the organisation and it is not part of the job.
Right, okay. So Naomi here has said that she works in a general practice, and she wants to know, should all staff be trained in de-escalation of violent situations, and should they all have training in the management of this? So some of the staff have attended the training session, but not all of their staff. And at the moment, their management there seems to consider that having one session accessible to all staff is sufficient. And although they have protocols and risk assessments, I feel that all staff and evidence of this really should be trained. What are your thoughts on that?
Well, I think that, you know, everybody has a budget. You must assess the utility of whatever training you're giving, and you need to look at the level of risk that you're seeking to meet by delivering that training. I don't by any means prescribe that everybody needs to be fully trained in control and restraint and all the rest of it. I think some simple lessons in how to de-escalate the situation would be quite useful. That could be delivered by an online service. Certainly in Wales, we do utilise that an awful lot now, and most people do have some form of de-escalation training. But it's a very difficult question to answer. I think that you need to make a logical assessment of the risk and the utility in the training in meeting that risk before you prescribe. Right,
okay. So on a quick one here, what do you mean by restraint?
I don't think I'll answer that question. It's too difficult, isn't it? In all seriousness, restraint is a massive topic. In this particular case, they did have control and restraint training, as you might expect for that type of unit. I'm not going to go through the specifics of what restraint is. There's lots of debate going on about it at the moment. There's always been debate about supine restraint and the rest of it. I can't give you a lexicon on that, I'm afraid, but nice question, nice try.
Okay. Someone asked, how can we transfer the document to the English NHS service?
Well, there's been interest by the government in England, and I think if there's anybody in the audience today who has a closer link to the English government or the Scottish or Irish government, then please just drop me a line. We're not precious about it. Indeed, many of the ideas have been pinched from other places. I'm not going to disclose precisely from whom or when, but we are not precious, and we want the whole of the NHS in the UK to benefit from this sort of initiative. And we want the message to go around generally in society that violence to NHS staff is simply not acceptable. The agreement that we put together contains lots of fresh posters. I forgot to show those posters, unfortunately, but they're all available to be downloaded. There's no cost involved in that. They're very effective posters. Publicity is everything, it seems to me, and getting that message around is really important. And I'm happy for my agreement to be promulgated wherever and how often you want to. So there's no preciousness about that at all.
Okay, great. What role do you see local security management specialists playing in pursuing violent incidents?
Well, I think that, that's a very good question. I think that it might be part of their role to assist in the same way as we envisage case managers assisting the police and the CPS in Wales. I think it is a similar role. Whether or not, there's been a lot of debate in Wales as to whether or not what we need is a dedicated violence and aggression case manager, or can that gentleman or lady be somebody who does a number of different roles, perhaps from the health and safety department or the security department. So it is difficult. And I think, again, it very much depends on the need, but I'll caveat that by saying that in order for us to be able to properly assess the need, we need engagement on this subject so that we get more incident reports, so that we can really and properly assess the true level of violence that our staff are expected or are routinely being exposed to.
Okay. Earlier you referred to the term capacity as a civil term and not criminal. Does this extend to all areas of health and safety? So, for example, bypassing a safety control if the service user chooses not to use it and upheld as they have the capacity. So an example of that being using a bed rail for comfort rather than a precaution.
Again, it's a tricky question, and I'm not quite sure I understand the import of it. What I would say is that when I'm talking about capacity, what I'm saying is a mistake has been made in police officers coming into a hospital environment and saying, there's been an assault, he or she did it, does he or she have capacity? The number of different definitions of capacity under the various different pieces of legislation that deal with it is vast, and the interpretation is very, very difficult. What we've done is we've said, look, that's the wrong term to use. Did they intend to commit the crime is all you need to consider in the first instance. And the more complex analysis will indeed be carried out at a later stage by the police, by the CPS, in detail, utilising the information provided by the clinical staff that will make an assessment of that particular issue. In terms of capacity, other than that, I mean, capacity is a legal term. It's also just an ordinary word that we use in everyday parlance. So it will have lots of different meanings. The meaning that I was trying to ascribe to it is as I just explained to you now. So in actual fact, what I do know is that the IOSH Health and Safety Social Care microsite on the main web page has lots of good information and resources about this subject. So perhaps if we defer to that.
Yeah, okay. So another person had asked with regards to, they basically said, was there a link up with other national bodies outside of the NHS? So for example, the HSE in Ireland?
There isn't at the moment a link up with HSE in Ireland, and we've tried to keep the HSE informed of what we're doing. We went far and wide in terms of looking for stakeholders when we revised this agreement, and I don't think there's anybody that we didn't invite, including a number of celebrities, would you believe, to try and help with publicity. But no, there isn't an established link at the moment, but part of the reason that I was very happy to do this was because I see this as perhaps a bit of a launch pad for this agreement, and for you know, some connected learning with other areas, environments, bodies who are concerned with violence in healthcare.
Okay. Someone's asked, how frequent do you complete staff training regarding management of violence or aggression in the healthcare sector?
Again, it does depend upon the level of risk that they face. So there are different levels of training that are given in Wales, which is a reaction really to the number it's a passport in Wales that we utilise so that people can take it with them if they move from one health board to another. But in reality, there's usually, if you're doing the highest level of training, I understand that there's an initial 4-day course, and then there will be a yearly refresher in relation to that. And I think that it reduces then, obviously, in proportion to the amount of risk that you face in terms of violence and the level of training that you then need.
Right. And what sort of training needs analysis and ongoing training do you see as being right for clinical staff in the NHS?
Well, this is one of the central opinions that I hold, so it's a personal opinion. My opinion is that there is too much of a wall between the training that is provided to people that work in mental health environments compared to people working within clinical areas. To me, somebody presenting with precisely the same cognitive decline will be better catered for, better controlled and managed in a mental health setting than they will be in a clinical setting, and that needs to change. Okay,
great. Interest in Wales, is training mandatory for all staff who interact with patients?
It's a really wide-ranging question, and I'm a lawyer. I've got to be careful in the way that I answer these things. Certainly, what I would say is that the intention in Wales is to ensure that all those who have an appropriate need for training in the de-escalation, prevention, management of violence and aggression do get it. Now, the extent to which we meet that rather lofty ambition, I can't confirm for all health boards. We are improving. It's under constant review. I'm working very closely with the Welsh Government. You'll see behind me there's it's a banner for the NHS Anti-Violence Collaborative, and the job of introducing the obligatory responses to violence in healthcare document has been seen as the first of many projects concerning violence and aggression, and the Welsh Government have asked me to continue as chair of that group, but also to invite interested parties who have issues in relation to violence in healthcare and social care to come forward so that we can try to address these issues holistically and collaboratively.
And is it going to be harder to implement since NHS Protect is no longer active?
In Wales, we don't have a particular difficulty in terms of implementation, and I think that certainly I didn't want to raise the A word. That's austerity. I think austerity means that budgets are being cut left, right, and centre, and everybody will be sharing that difficult conundrum. When it comes to prevention, it's very difficult to sell when you're comparing yourself to a service need, the service delivery of healthcare. We do sometimes come low down on the list, and we're hoping that we can improve that by demonstrating that the things that we're suggesting will increase the coffers of the NHS by saving them significant amounts of money in the longer term and meeting a problem before it gets out of hand.
Mm. Okay, there's a couple of questions I'm gonna kind of combine here. So this person says, how is verbal abuse dealt with effectively from a legal perspective, especially in a mental health setting where zero tolerance, which is often bandied about but is impossible to implement effectively? An additional one on that is, what are your thoughts on zero tolerance within NHS settings?
Look, I'll be quite clear. The idea of zero tolerance is a good one. Again, it's a lofty ambition. I think as a lawyer, I'm open and honest enough to understand that we'll never get rid of it, we'll never eradicate it. I think that the term zero tolerance is probably a little outdated now. I think we need a better proxy term, which is perhaps going to grab the attention of the public and the staff within the NHS. I think when you have something with such a lofty ambition that's been around for such a long time, and I'm not saying it hasn't worked, I'm sure it's deterred a lot of people from violence, but it certainly hasn't eradicated it, and therefore I think a different term ought to be utilised now. Going back to the question more specifically, it seems to me that to suggest that you're going to have zero tolerance to verbal abuse in a a mental health facility is perhaps an impossible dream. The very nature of the patient is going to mean that's very, very difficult, I think. And are you going to be able to get them to comprehend why that is the case? Who knows? I think it's a question for clinicians as much as for lawyers, to be honest.
Okay, we've got time for maybe just one or two more. There are a lot more, so I'll put these to you in writing afterwards. But one person said that in the case study, you noticed a breathalyzer as equipment, and in that case, not relevant. Was consideration given to the provision of additional restraint equipment?
I think that the consideration for the needs of restraint was appropriate in the case. I think that we didn't need any equipment. I mean, I don't know whether you're talking about some form of device to restrain. That wasn't something that we felt was appropriate, and I don't think it's something that's on, it's not in our store cupboards in Wales at the moment. Certainly, we tend to use physical intervention, not with mechanical means. In terms of the breathalyzer, I mean, what I was saying in terms of what the judge was saying in terms about the breathalyzer was, it was criticism of the fact that although we suggested to the individual that he would be breathalyzed, we didn't follow through with that, and they were trying to suggest that was some form of breach of duty. And when the judge analysed that, he said, "Look, hang on, the breathalyzer was irrelevant to the onset of violence. So you can't say that is in actual fact a breach of duty." And it was explained that it was the deterrent effect of the threat of the breathalyzer that had more utility than anything we could have done. What are we going to do? Ban him from driving? He's not driving a car, is he? He's just going to be told he shouldn't have done it and that he's at a high level of intoxication. And as the judge rightly pointed out, it would have been negligent of us in a clinical negligence sense to have discharged that gentleman at the time, simply by dint of the fact that he was intoxicated. Indeed, he'd have been a danger to himself and potentially to other members of staff or to other members of the public if he'd been wandering around that night.
Okay, great. There are a number of questions still here, but we have run out of time. So, Andrew, thank you very much for delivering this session. That's really, really informative, I think, and a lot of people have said some really, really positive things about the session. So, thank you for that. Thank you all for attending as well. I hope you found the session enjoyable, and hopefully we'll see you again at future ones, and I'll be in touch in due course. So, thank you all for attending. Thank you very much, Andrew.